Hello, my name is Todd Brookens. I'm your medical director for Sylvania Township Fire Department. I wanted to take this opportunity to go over a few airway tricks that I think will really help you succeed whenever you have an emergency airway situation. So the first thing I want to talk about is when you approach a cardiac arrest, I want your first airway and first ventilation be through the eye gel. We've been seeing some challenges with intubating in the field with cardiac arrest in particular, and pretty much the trend across the country and evidence-based literature demonstrates that you're better off going right with a supraglottic airway. So even if you have a bag valve mask present, really the best way to ventilate a patient is to just put the eye gel right into the trachea and ventilate through that. When you do ventilate through the eye gel, make sure you have an end-tidal CO2 device on, and then give tidal volume breaths through that. The reasoning is then you can focus in on more important life-saving interventions such as high-quality CPR, early defibrillation, early epinephrine administration through an IO. So go straight to the eye gel. If you need to intubate later, you can do that, but hopefully it'll be in a more controlled environment, perhaps in the back of the ambulance with excellent lighting. Okay, next I'd like to move on to the various laryngoscope blades that Sylvania Township has. The first one you'll see here is called hyperangulated. This blade can only be used with a hockey stick stylet. My preference is to have a prefabricated stylet. We don't have those here, so this is a normal malleable stylet, but it needs to be in this position. You cannot use a bougie and have success with the hyperangulated blade. Okay. This is a number 4 blade, and then this is the standard geometry Macintosh blade. I believe this is a number 4 as well. With this blade, you can use either the hockey stick or you can use a stylet. And my preference with this blade in particular, the normal standard geometry blade, is to use a bougie. And then to have your partner load an endotracheal tube over the bougie as you watch it pass through the cords. All right. Another trick that I'd like to go over is during laryngoscopy, I want you to lead with the Ducanto, not with the blade. So when you're entering the mouth, I want you to hold it like this. This is the proper way to hold the Ducanto catheter. And then you can scissor the mouth open and lead with the Ducanto just like this, gently into the posterior pharynx, and almost use it as a tongue blade. Leave it in there and then gently advance your scope blade into the proper position. This is particularly useful in a soiled airway such as vomit or blood, and it really helps to avoid fogging up the camera end. So always lead with Ducanto, so make sure you have your suction device at the right side of the patient's head. Hold it like this, grip it like this, scissor the mouth open, gently enter it into the right side of the mouth, suction, 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 and then whatever blade you choose, you can slowly advance that. All right, now I'd like to go through some different techniques for laryngoscopy. My goal for whoever is going to be doing the laryngoscopy on the patient is that they are an epiglottoscopist. So you are planning for success, but the way you're going to have success is by incrementally advancing the blade and finding landmarks as you go. So the first landmark that you're going to see when you enter the mouth would be the base of the tongue. You need to be watching for that on your screen. So don't just expect success by bearing the blade immediately. You have to march it down across the normal anatomy. So here as we enter, you can see the base of the tongue right here. And the other landmark that I want you to notice is the uvula, the punching bag at the back of the throat. So we need to be noticing these landmarks so that we know that we're in the right position. This helps us to know that we're in the midline. You'll also notice right at the back is the epiglottis, and that is our goal. So we're going to slowly advance across the base of the tongue into the vallecula, which is our goal, and gently pull back until you see the tracheal structures come into view. So remember, this is a hyperangulated blade, and in order to have success, you have to have the hockey stick. I always recommend entering the mouth at a 90-degree angle, and as you enter and you see the tip, to rotate to the normal position and pass the tube. Notice that I don't have a perfect view of the glottic opening. What we don't want to see is that. You will not have success most likely if you have such a great view. That's the beauty of the video laryngoscopes. So the view we want to have, remember, here we have the uvula, base of tongue, and then we're going to slide this into the vallecula right there. Pull back, hockey stick 90 degrees, enter into the side of the mouth, rotate into position. Okay. Another thing that can help if you have not a very good mouth opening is to have your partner fish hook, I call it, the cheek to open up the airway. Okay. Another part of the anatomy that I want to identify here is this. This is esophagus. So this is not where we want to be. A lot of people think that they don't go high enough. They think that that's the airway and they pass the tube through there. Okay. While we've got the hyperangulated blade in place, I want to show you a technique that is helpful in a soiled airway. So remember, we entered in here with suction, 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 suction. This whole airway may be occluded with debris. Sometimes you will have just one view of the glottic opening while you've got Ducanto here. And what you can do is gently pass it through cords, gently. This is a very rigid suction catheter. And then have your partner take the end of the suction off of the Ducanto, leave Ducanto in place, and gently pass a bougie through. Watch the bougie pass through the cords. And then you can gently take the Ducanto out, leaving bougie in place. And then your partner can anticipate you're going to need an ET tube to go over it, to railroad into the airway. Like so. Okay? So that is a technique that is available to you. I would not recommend this on a routine basis. This is if you're suctioning, and there's blood, vomit, debris, all kinds of stuff just pooling up in the back of the airway. This is called a salad airway, and we have videos that we can show you on that. But if you have the opportunity and you see the cords, that might be your only opportunity. So once again, you're suctioning, and you can gently pass it through the cords, gentle, because you can rip the cords off. And again, pass bougie through. Pull Ducanto out. It's usually a two-person technique. I'm just showing you with one person. And railroad the ET tube into proper position. Notice how I leave the scope in place, so I see the balloon pass through the cords into the trachea, and then this can come out. Your partner can blow up the balloon, and then a tidal volume breath can be given with end tidal CO2. So that's the gold standard way to do it. All right. I'm going to switch blades to the standard geometry Macintosh blade. So the same is true with this one. You want to be a laryngoscopist, an epiglotoscopist, and incrementally advance the tube, expecting to see landmarks. So you can see here is base of tongue, and here we have uvula, the punching bag at the back of your throat. Coming into view as we go around the curvature, the normal anatomy of the airway, we see epiglottis come into view, and you gently go into the vallecula, gently pull upward, and you'll begin to see your glottic opening come into view. This one I prefer to use the bougie with, passing the bougie through the cords and then railroading the ET tube over the top. The Ducanto can be used for the soiled airway in this situation as well. Suction, suction, suction. Oh, I see cords there. I'm gently passing it through them, and then the bougie can be introduced through Ducanto into the trachea, gently sliding Ducanto out, leaving bougie in place. And then railroading the ET tube into the proper position. Now, as you all know, the gold standard for confirming an airway, an advanced airway, whether it be an ET tube or a supraglottic airway, is end-tidal CO2. So trust your device, trust your equipment, and if you do not get a reading, your airway is most likely not in the proper position. So use your senses, use your examination findings, but rely on your waveform end-tidal capnography. And if you do not have a waveform, pull the tube and restart, okay? One other trick, this patient is completely supine. This is not the ideal positioning for intubating. If you have them in a confined space, put the supraglottic airway in first, extricate them out, plan an egress to a well-lit area, put them on the cot, and then raise the head of the bed 30 degrees. If you are ever seeing one of your partners trying to intubate a patient supine, just say, hey, let's lift the head up. Just reach behind, grab the handle, pull it up to 30 degrees. This is ideal positioning for intubating. It helps the jaw to relax. If there's any soft tissue, it pulls them away. The other thing is this patient has a collar on. This is simulating a rigid cervical collar. So if you have a trauma patient that you're wanting to intubate, take the collar off. Have someone just hold manual C-spine. That will really help to open up the airway and give you chances for success. So, to summarize the topics today, 2 blades, hyperangulated, standard geometry. I don't care which one you use. Whichever one you decide to use, make sure that you are being a vigilant anatomist, epiglotoscopist, laryngoscopist. Okay, so you're following the anatomy down gently and expecting to see certain structures: tongue, uvula, punching bag, vallecula, and then the epiglottis coming into view. Slide into the vallecula and gently pull into position. If you have a soiled airway or an anticipated airway that's going to be soiled, I'm always recommending that before you even start this, that you're leading with Ducanto, and that this is the proper way to hold it. So you have your suction canister right here by the right side of the bed, and you're using this as a way to, almost as a tongue blade, to help open up the airway, and this will greatly enhance your success. Then you can advance the blade, leaving suction in place. If you do have a soiled airway and you have one chance to see the glottic opening, this is fine to use, but be very careful because this is very rigid. You can really damage the trachea, you can puncture the trachea, you can rip off a cord. So not to be used all the time through the trachea, but if you have that situation, then this is an option for you. When you're using it that way, you'll need to place the bougie down the center and through the cords. And one other reminder, if you're using the hyperangulated blade, it has to be used with a hockey stick configuration. Preference is the manufactured stylet, but this is the one that we have. And then you enter at 90 degrees, and once you're into the back of the throat, rotate to midline. And then the final emphasis is on cardiac arrest. This is your go-to airway right off the bat. Get in the door, high quality CPR, whoever's at the airway, slide this in with end-tidal CO2 attached to the top, and your first breath, we have that waveform right off the bat. Trust your instincts, trust your equipment. If you have no waveform, pull it out and troubleshoot. So I hope this is helpful for you, just some tricks that I use in my own practice that are validated across the country and across the world as best practice. And this should really help with your advanced airway techniques. Have a great day.